Hi guys, we are back for another end-of-life lecture on ALS, amyotrophic lateral sclerosis. This is the only exemplar I'm doing a PowerPoint on in end of life. I know there was another one on pancreatic cancer and one on senescence or aging, but we talked about aging back in interpersonal relationships and also in human development. And then we also, pancreatic cancer, we've addressed cancer pretty thoroughly. It's a solid tumor. And other than the fact that it's highly fatal for almost anybody who gets it, there's not a lot I feel that needs to be addressed there. So I wanted to just address amyotrophic lateral sclerosis because I don't know if you get it anywhere else in our concept curriculum. So I'll do this voiceover for this PowerPoint. The reading for end of life is primarily in your Lewis chapter. You have a chapter towards the beginning on palliation, palliative care. Then you also have a chapter in Potter and Perry on death and dying, and you have a chapter in Barcarolis on death and dying. Let's see. I'm just going to check that chapter for you. It's chapter 30. Now, in Potter and Perry and Barcarolis, the same chapter will also be referenced in the grief reading. But in Lewis, there's not grief reading. So that's how the reading is going to go in these last two modules. Let me share my screen with you and we'll talk about amyotrophic lateral sclerosis. Okay, so you are seeing the slides on amyotrophic lateral sclerosis. This is also classified as an autoimmune disease. You know, we did the other autoimmunes and immunity at the beginning of the semester, but this one's significantly different enough that we pull it out and cover it only in end of life. So the ALS is also known as Lou Gehrig's disease. Lou Gehrig was a very famous baseball player in 1941, played with Babe Ruth and some of the other greats with the Yankees, and he died very young from Lou Gehrig's disease, or amyotrophic lateral sclerosis. This is a disease of the motor system neurons, the spinal motor system neurons. It does not affect sensory symptoms. So the patients can still hear and taste and see, but their motor movements are definitely damaged. This disease causes progressive muscle atrophy from damage to the nerves that also then feed the muscles, and the muscles continuously atrophy until they just can't function. The patient will die within 2 to 5 years because the diaphragm will atrophy, the intercostals will atrophy, and the patient literally just will not be able to breathe. There is no cure. It's most commonly diagnosed in the 40s, 50s, and 60s, up till the 70s, in men more than women. So this is primarily men and middle-aged men. There's no respecter of race, cultural, or socioeconomic group. All races and socioeconomic groups die equally from this very devastating disease. So this is just a little infographic created by somebody for the Tribune in Salt Lake City, but it just talks about it. It's a progressive neurodegenerative. The nerve cells deteriorate, and it destroys the spinal cord motor neurons that innervate the muscles that in turn cause the muscles to atrophy. The neurons tell the muscles to contract and move, and they're not able to send that message anymore. About 10% of these cases are inherited. There is a genetic link, but that's the vast minority of the cases. There's a few other risk factors we'll talk about shortly. No cure. Death is likely to occur in 2 to 5 years. So amyotrophic comes from the word atrophy or muscle wasting. Lateral sclerosis is hardening, sclerosing, scarring of the spinal motor neurons. So it starts usually in the arms and the legs, and eventually then it moves throughout the body and up the body until the central core muscles, including diaphragm, chewing, neck muscles, everything is affected. So, but it's all muscle groups and it's motor neurons. So this shows you what a normal motor neuron with good myelin coating would look like. And the ALS, the neurofilament buildup, and the disease nerve fiber, which then cannot transmit effectively to the skeletal muscles, the voluntary muscles, and involuntary muscles. And the muscles become wasted and unable to move in response to neurologic innervation. So we think, well, we don't know what causes it. We absolutely don't know. There's some suspicion. Is there dysfunction in the neuron and the mitochondria of the neuron? There's some evidence to support that. We know that there's a gene, a defect in chromosome 21 that can be linked to this, but that's a small percentage of the cases. We also know there's geographical pockets that this has happened in. Guam and the Trust Territories in the Pacific Islands was where there was one extremely high incidence pocket in the late 60s and 70s. And what they discovered was there was a seed in a plant that they used to make flour out of in these islands, and it had a neurotoxin in it. And so they believed that was responsible. But we don't use that seed in the United States, and it's not used in our food products routinely. And so yet these cases still happen all over the world, even in the United States, without that incidence. Then there's the suspicion is that free radicals might cause that. The same things that cause mutations of the cancer genes can also contribute to the development of ALS. We also believe that there might be some glutamate excitotoxicity. Glutamate is a neurotransmitter that excites our neurons, and they think that there may be an overflowing of that floods the neurons and actually becomes toxic to the neurons and destroys it. There is some suspicion that a viral disease may instigate this disease, exposure to a virus like Epstein-Barr or something similar. And then, of course, we believe there's an autoimmunity link where the patient is fighting their own body. But basically, we don't know what causes it. We don't have treatment. We don't have cure. So the patient usually starts with weak muscles, dysfunctional, clumsy muscles in the arms and the legs. They drop things, they fall, they have trouble climbing stairs, they can't turn the keys in the car ignition. Their tongue might fasciculate, twitch when at rest. They're tired and their speech is slurred because the muscles that articulate speech are not functioning correctly, and they may have become difficulty swallowing. Those are very common signs and symptoms. Just remember that's motor neurons that we're seeing the effects in. So the patients can't do normal ADLs. They have trouble walking, they trip, they drop things, they're always tired, their hands are clumsy. And again, slurred speech, trouble swallowing, twitching in their arms, shoulders, tongue, legs. And they might not even be able to hold their head up well to maintain good posture. So how would we diagnose this? Well, there's not let's just do this blood test and sure enough, it's ALS. We do a nerve conduction velocity test and an electromyogram to determine if the nerve conduction is adequate and if the muscle strength in response to a nerve impulse is adequate. Both of those things are declined in a patient with ALS. We put in multiple electrodes along a nerve pathway and stimulate that nerve to see then if it is able to get a signal to the muscle. And then we also implant multiple electrodes into a muscle group, stimulate it and see if the muscle will respond to nervous impulses. Those two tests generally show slowing. We can also biopsy the muscle, see the atrophy. MRIs and other blood tests and lumbar punctures are primarily used to rule out other stuff, rule out MS, rule out Lyme's disease, rule out neurosyphilis, rule out the other diseases that might cause weakness, clumsiness, and lack of response to nerve impulses. A picture of Stephen Hawking, another very famous person who had amyotrophic lateral sclerosis, famous physicist. He was responsible for several books that were written about the evolution of the universe, as well as major physics discoveries, but he had ALS. He was one of the longest living patients with ALS. There's a couple of strains of ALS. 90% of ALS patients die within 5 years. Stephen Hawking's actually lived 15 or 20 years after diagnosis, and it's highly unusual, very rare. Okay, and here he is in college. And this next slide is what he looked like as this disease developed. You can see he's still a young man, not able to support himself, and at the end of his life in a wheelchair. He had a computer that responded to his eyes, and so he could make his computer type and promote artificial speech for him. Pretty impressive, all the technological support that he was able to have. Okay, at late stage, more and more muscle groups are affected. The patient is completely incapacitated, can't walk, can't feed themselves. They generally require a ventilator and have to have artificial ventilation to breathe. They'll have to place a feeding tube because they'll lose the ability to feed and swallow. The patients are scared and anxious. Remember, sensory organs are intact and their ability to think remains intact. So they know they're deteriorating, they know they can't move, and they cannot do anything about it. They cannot breathe, and they can't make themselves. They cannot swallow or chew, and they cannot make themselves. So they become completely bedridden or wheelchair-ridden, ventilator-dependent, completely reliant on others for ADLs, unable to move anything. Our focus for these patients, because there is no treatment, is to maintain a high quality of life as long as possible, control symptoms as much as we can, and prevent complications like pneumonia, skin breakdown. We'll use adaptive devices as long as possible until their muscles become completely incapacitated. So they'll have supportive devices. They may use a walker for 6 months or a year. They may be able to use adaptive spoons and forks or use Velcro dressing things that help themselves dress and undress for a period of time until the atrophy of the muscles becomes so complete. Physical therapy can help with the pain that might be experienced as the muscles atrophy. Stretching will help avoid contractures, and we don't want the joints to become immobile. The dietitian is going to make sure they have high calorie, high energy foods. The patient's going to be tired all the time. The mitochondrial dysfunction is making massive amounts of ATP to try and send that nerve impulse that's not actively getting there, and lots of conscious thought trying to override ATP to make muscles contract that just don't respond. So the ATP is made in high volumes. They need high calories. They're going to have wasting and all kinds of problems if we're not able to sustain their food intake. They'll use splints on their arms and their hands and their legs. And of course, speech therapy to help with swallowing, occupational therapy to help with muscle movement as long as possible. There is one drug, Riluzole. And this is the only drug that's approved for ALS. And what it does is prolong life for a few months. May delay the use of a ventilator for a few months. It doesn't fix anything. Prostatin is a MAP4K inhibitor. Means nothing to you, I realize. This drug is in clinical trials, is being used, but we have not had any better success with it. Right now, the only drug approved to treat ALS is Riluzole, and it has all it does is prolong life and delay ventilator onset. We do use, for treatment of symptoms, baclofen. We talked about that when we did MS. We talked about it with CP. This is a muscle relaxant that helps prevent spasticity that might come along as the muscles are atrophied. Dantrolene, that should be Dantrolene. I apologize for the typo. Dantrolene, that's another muscle relaxant. That's the muscle relaxant we used with neuromuscular malignant syndrome that came along with anesthesia. Diazepam, another muscle relaxant, mostly just to prevent muscle spasming. We can give NSAIDs to relieve general pain, like ibuprofen, naproxen, longer acting, and then tramadol, like a low-grade, mild opioid for pain relief. Depression is super common. The patients, remember, they retain all their awareness and their body is deteriorating, and with a likely death sentence in 2 to 5 years with an untreatable, irreversible illness. So depression is common, and antidepressant meds and counseling can help patients and families cope with this, because to watch somebody deteriorate, your loved one deteriorate in front of your eyes, and have them not be able to communicate with you, eat with you, do any activity around the house, or interact with the family. Okay, so while the person is able to speak. We did end of life stuff earlier. While the person is still capable of participating in their own decisions and signing their own name and speaking to express their concerns and their wishes, we want them to create an advance directive, a durable power of attorney if they need one. So directed to the physician, durable power of attorney, sign all their legal documents, wills, and everything to avoid probate, or to do whatever they can to get their affairs in order and achieve closure and get everything done with the legal process. Now, hospice and palliative care can help with that. They can have legal representation, or that they can help the patient find or provide for the patient. And they also can have legal assistance if the patient experiences discrimination, or insurance companies try to drop them. So we can certainly help with legal intervention. We can't do that for them. We can make appropriate referrals and get them into palliation and hospice as early as possible, because we want them to have the full benefit of all the palliative care support. Most patients, half of them die within 3 years, 20% live 5 years, 10% live 10 years. So really, really bad outcomes, 100% death. Hospice can prepare dignity for this patient and help the family prepare for death and help them get all their affairs in order and treat their symptoms as they get closer to death. They can help them acquire durable medical equipment they need as the patient becomes more incapacitated. So here's a test question for you just to check your memory. Robin is seen by her primary physician. The physician is trying to rule out MS and ALS. What symptom would indicate a diagnosis of ALS? Ataxia, dysphagia, and vertigo, diplopia, nystagmus, and intention tremors, tongue atrophy, tinnitus, and ataxia, or fasciculations of the face, dysarthria, and dysphagia. A lot of words in there. So remember, this is a disorder of motor neurons. So any symptom in there that's a sensory neuron is probably not my right answer. So vertigo is sensory. Diplopia, double vision, that's sensory. And tinnitus, ringing in the ears, also sensory. The only answer that has all motor neuron innervation is fasciculations, that's twitching in the face. Dysarthria is difficulty speaking, and dysphagia, difficulty swallowing. All three of those things are commonly found with ALS, whereas an MS patient might have double vision, nystagmus, a tremor, probably has gait ataxia. Certainly dizziness is very common with MS. So the first two are primarily MS. Tongue atrophy, don't even know where that came from, but those are not symptoms of either usually. It's D. D would be your proper answer. So thank you, and that's the end of this slideshow. I'll get it posted for you. You kind of understand the basics of ALS now.